Welcome in, everyone. Thank you so much for joining today. Today is our 6th ED Stop Suicide QI collaborative session. We can just wait one more minute for a few people to file in, and then we can get started. Welcome in, everyone. Thank you so much for joining today. Okay, we can go ahead and get started. So again, thank you so much, everyone, for joining today. Today is the ED Stop Suicide QI Collaborative's 6th session. We hope you all have been having an amazing summer so far. Thank you so much again for joining. We can move on to the next slide. So the EMS for Children Innovation and Improvement Center is funded by the Health Resources and Services Administration, also known as HRSA, within the Department of Health and Human Services. The Pediatric Mental Health Care Access Technical Assistant Program is also supported by HRSA. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next slide. Nurses, please remember you must add your first and last names into the main collaborative session chat feature. You're able to see that right now, so go ahead and add your first and last names, please. At the end of the session, you will be able to use the QR code or the link given in the chat to be able to complete the evaluation to secure contact hours or CE. Unfortunately, we will not be able to offer CEU for social workers for this session. We sincerely apologize about this, and things will be back to normal for the future October and November sessions. Again, we really apologize about that. The before and after portions before the breakout groups of the session are being recorded and will be posted to the EIIC website. So we are going to start out today with a presentation from Jen Donathan on community outreach strategies to support your ED's clinical care processes. Jen serves as the project manager for the EIIC's supplemental funding work with HRSA's PMHCA program. This work supports the development of technical assistance for PMHCA partners in identifying and addressing pediatric and adolescent mental and behavioral health needs in the ED through the use of teleconsultation and telehealth. She brings with her over 9 years of project and program management experience, coupled with her expertise in public health and healthcare quality. Next, Dr. Mo Saeedinejad will be giving a presentation on recent improvements reported by teams and addressing barriers. Mo serves as a professor of emergency medicine and pediatrics at the David Geffen School of Medicine and director of pediatric emergency medicine at UCLA. He also serves as the director of patient experience at Harbor UCLA Medical Center. Mo additionally is the EIIC's knowledge management domain co-lead. After these brief presentations, we will split off into our breakout groups for a little bit under an hour to discuss QI project updates from this summer, and then join back together for the last 15 minutes to hear about a small win or a QI project update from this summer. Lastly, we will discuss some next steps and dates for awareness, as there are only 2 collaborative sessions left after today's. So please stay until the end to complete the session evaluation poll. And for any questions you might have, go ahead and put them in the Q&A chat feature, and we will get those answered. So we can move on to the next slide. So here are the formal objectives for today's session. And with that, I will now turn it over to Jen Donathan.
Thanks, Lenny. Hello, everybody. So before we dive into establishing community partnerships, we really need to define what that means. And so here, just from Nacho, describing what a community is, really looking at the aggregate of persons who share common characteristics such as geographic, professional, cultural, racial, religious, and socioeconomic similarities. So what does that mean in terms of a partnership? That's a working relationship between that's cooperatively working towards a common goal. So this includes a range of levels of participation by organizations and members of the community. And these levels are determined by the degree of partnership that you're seeking, the frequency of the communication you'll have with these groups, the equity of decision-making, access to information, and the skills and resources of residents that you are bringing into the fold. And again, a community collaboration is a dynamic, ongoing process of working together. If you go to the next slide. So who to partner with? So just reiterating that when we say community partnerships, they're not just local. As you can see by this pyramid graphic here, it can be from individual all the way down to grant makers and funders. So really the breadth of a community partnership is broad. But there really are three distinct groups that play vital roles in your partnerships, looking at state and community partnerships, support and intermediary organizations, as well as grant makers or private foundations. If you go to the next slide. So really you need to determine where you want to start. There are different levels of partnerships that you can engage in. If you look on the right, you see an arrow pointing down, green going to red, green being the lower level of engagement versus red, the higher level of engagement. So networking, cooperation or alliances, coordination or partnerships, coalitions and collaborations. As you move down this table, the more that will be required of you in establishing those partnerships. All right. So really where you want to start, once you determine kind of the level of partnership that you want to engage in, you need to develop your list of partners. So first, identifying who needs to be involved in order to accomplish your goals. Reviewing for completeness, making sure that you've accounted for everybody that you need in your partnership. And then really from there, begin the outreach and considering emerging leaders, not just those at the tippy top of the spectrum, but also those kind of younger and more up and coming individuals. Those are other individuals that you would want to consider in your partnerships. From there, it's really creating transparency and trust with groups, sharing your goals, sharing the why, the impact, and the vision for collaboration, but also really listening to them as well. You can come in with an idea of what you want to do with your partnership, but it's really important that you get to know your partners as well and seeing if those goals align. So trust is a key and crucial part of forming these partnerships. If you go to the next slide. A big component of building that transparency and trust is establishing a charter. So what's the role of this? It lays a roadmap out for the project work that's at hand, getting everyone on the same page with what your goals are. It provides rationale for the work being done, as well as outlines the scope of the work. Also defines the roles and responsibilities of team members, not just within your team, but also what your expectations are for your partnerships. And again, of the utmost importance, just creating transparency for all who are involved. Go to the next slide. So PMHCA partners, here are just a list of the different individuals that they've been engaging with. And again, these strategies have been based on aligning the goals that they have, but also looking at the goals of their stakeholder groups. So they've considered organizations from state legislatures and primary care offices to universities, parents, public health departments, school administrators. The future is also including the youth voice as well. But again, a crucial part of establishing those partnerships is one, making sure that goals align across the board. And maybe there isn't necessarily like equal alignment, but there's the ability to collaborate and seeing what one can do for the other. But again, trust is a huge component of establishing those partnerships.
All right, I guess I'll take over from here. I'm Mo. So I'll be talking about the second and third objectives. So first, I wanted to go over some of the survey results for those of you who completed surveys, and thanks again in advance for having done that. This is our mid-collaborative survey results. Next slide. So out of the 78 teams currently in the collaborative, 34 completed the ED Stop Suicide Check-in survey. And down here you see the bundle that each of the teams chose. The more people chose the discharge and safety planning, that is clearly a very important area. And less of you, like only 2 teams, chose the assessment, which essentially means after somebody screens positive for suicide risk to do the assessment to see how immediately or how urgently the patient requires care or whether they need to be admitted or not. Next slide. So the great news is that all of your teams who participated in the survey were able to identify at least one strategy to improve a clinical care process in your ED. And about 3/4 of you guys have already started implementing or have already implemented a strategy to improve the clinical care process. Most of you, 94%, have not been able to demonstrate an improvement, and that is not unusual. Demonstrating improvement takes a long, long time. This is a 9-month collaborative from beginning to end. So some of this is going to be delayed a little bit, but the fact that you've already identified a strategy and started implementing at mid-level here is excellent progress. So you guys are doing fantastic job. So thank you again and keep up the great work. Next slide. So just wanted to mention that some really exciting ideas that you guys have shared that you're working on, these are all very important. The idea of universal screening versus targeted screening. So some of you guys are working to implement universal screening in your setting. The handoff tool is incredibly important because, you know, errors usually happen during handoff. To have a standardized handoff process is excellent. Also, resource packets, care notes, integration into the EHR is super important if you're going to get some traction and be able to get a lot of people participating. It's always important to have things integrated in your EHR. Makes it much more seamless, much more easy for people to follow. Also very important is the distraction kit. We have shared with you the New England distraction kit in our EIIC pediatric education and advocacy kits. So it sounds like people are using that as well. Neurodivergent children, very, very important. They are a little bit different the way you manage them. They have different triggers. They interact with the environment differently. To have sensory cart for them, that's an excellent project as well. The use of the SAFE-T and the Columbia risk assessment tool, again, very, very critical. And some of you guys got creative and looked at adjusting the screening age from the recommended 12 years down to 10. And I wouldn't be surprised if this goes down to 8 years in the coming future. We're getting a lot more and more younger kids. And we are showing studies that the risk of mental health presentation to the ED among the 5 to 9-year-olds has increased tremendously. And as a matter of fact, we just recently talked about that suicide now is a top 10 cause of death in children between 5 to 9 years of age, which is very scary. I have a 9-year-old and I can't imagine that that's the case. The family information sheet related to mental health visit is also super important. So we're really excited to see how these all develop. Every single one of these is super important and really very creative. So thank you again for sharing those with us. Next slide. So now I want to talk about the real problem, the barriers. And this is not what you specifically will encounter, but everybody will encounter these. And I want to share this with you so you kind of get a little bit of a warm, fuzzy feeling that you're not alone. This is a difficult process, and it is something that you have to be patient with. Next. So one of the major things to think about is every time you go in, you walk in there and you try to make a change, you're going to run into resistance. Nobody really likes that. Everybody's comfortable with the way they're doing things. So you have to go in there with the thought of, this is really a better mousetrap. This is a better way to do this. And you need to support this with tremendous amount of evidence. You have to also show each person what's in it for them in making this change. And essentially, you'd have to show that it makes their life easier. It makes their ability to care for patients easier. And that's kind of one of the ways that you get around it. Culture is very difficult to change. This is not the way we do it here. This is not how it's done. At my institution at Harbor UCLA, we have a zillion things that are called Harborism. That is just the way we do it, and it does make no sense, but it's traditionally been like that, and changing it is incredibly difficult. So you have to start by first getting buy-in from the people closest to you. You have to basically make the proof of concept that this really is amazing. This is going to make things better. It's going to make everyone's life better. Once you get buy-in from staff, the more difficult will be getting buy-in from leadership. So you have to support your claims to leadership with data, especially if you can come up with financial data, resource data, saying that I can do this with minimum amount of hiring. We can do this without having to change many processes involving many people. And then you have to go and do this at the larger state level buy-in. And those are all difficult. They all take a lot of patience, a lot of persistence, a lot of hearing no's and saying, okay, let me try it again. So you also need to think about what your environment looks like, whether you have adequacy of your staffing, whether you have enough personnel to get this done, you have enough people working with you on the team. And then you have to figure out, once I have convinced the people around me, how do I infiltrate this outside of my immediate area and get everybody else to buy in this, because this, at the end of the day, pretty much everybody needs to buy in. It's not like starting Monday morning, we'll be doing this. It will be, everybody knows that Monday morning come, this is going to happen. This is not going to be an announcement that nobody knew about. This is something that everybody would know about, and that's usually your best way of succeeding. Next slide. So again, it takes time, especially if you're the lone voice. So you have a lot of convincing to do. It is very important for changes, and we talked about this a little bit ago, about integration into the EHR. If you can put mental health related discharge processes into your EHR, then it's right there. You don't have to click anything extra. It's not something new. You just go on the mental health piece, and it's the same as interventions regarding any other medical case. And normally there aren't a lot of EDs that have mental health education resources that are part of their traditional ED discharge kits. We get these standardized ones that come with a bundle we purchased, but they're not nearly adequate for what we need. So we have to build some custom ones. But it's good if they all kind of show up in the same list, so you can actually be able to process them very much like you do processing every other discharge instructions. The other thing is that, what do we do with the patients who are low risk? Because the low risk patients may not immediately need intervention, but they are still risk, and they still potentially need to be connected to resources. They need to be connected with follow-up, and to be able to have a real nice ED to psychiatric subspecialty discharge order that actually says follow up within this many days. And it would be nice if it actually, that order went to a receiving area for pediatric mental health, and it would be even better if you get a response back that says Tuesday morning at 9 a.m. they can come to the clinic and visit. Things of that nature, they all make your barriers a little bit more easier to overcome. Next. So one of the other things is that oftentimes when you come up with an intervention, it is difficult to know, how am I going to actually measure the outcome of interest? How am I going to know that this is working? What is my criteria for defining success? Do I want to see an 80% reduction in number of clinic visit, no-show follow-ups for mental health, for example? So it's very, very important for you to know what your outcome of interest is, and know how to measure that, and be able to have numbers, because you need that to show it to your hospital leadership. You also have to know, what is your threshold, what is your target, what's your maximum in terms of measuring your success. So you can say, we set out to do this, and we are about this successful because these are the metrics, these are the numbers we looked at. It's also nice to benchmark. So you guys are part of a collaborative. You can kind of touch base with each other and see how on something similar the others are doing, and you can benchmark yourself against, hey, you know, it sounds like at least if we get this percent, then we are within the acceptable limits of having to be able to demonstrate success. And there are also challenges when you don't have clear evidence, when your data doesn't back you up, if you don't really have anything to show that this is actually a good initiative that actually succeeds. So it's very important to set those up front and make sure that you set yourself realistic expectations. One of the biggest challenges is when people overthink and overpromise, because change is slow. It's going to be small increments at a time. So don't go in asking for 80% improvement in something. You got to be very, very meticulous, especially when time is short and you only have months to a year to do this. Next. So things that you guys have also shared with us in terms of things that you are considering as barriers. One is that if I were to outsource this problem, if I were to try to get community involvement with mental health services outside of my current network, what would be the cost of those referrals, and can my system afford that? Do we have agreements with that group, and is it sustainable? And what is the best way to get every patient with mental health, regardless of the acuity of the problem, providing them initial care, providing them ongoing care, and connecting them so that when you refer somebody to a outpatient psychiatry, you actually get some information of whether or not they actually ever went there or not, especially if they're not part of your system and you can't look it up. So it's very important to know whether you're actually providing that continuum of care. Next. So again, major points from this is that very, very important for staff that you work with to feel like this is not your project. It's everybody's project, that they have had a say in it. They have ownership of it. They kind of feel like when they talk about it, it's not that I'm talking about Mo's project, I'm talking about our project. This is incredibly important to have that level of engagement from staff, so it doesn't come across as you as one person is spearheading this. It's really a team that's spearheading this. You just spend a lot of your time generating buy-in, enthusiasm, and collaboration. And also remember, with the EHR integration, it's not just your local, but it's in a larger network. So in my system, for example, when we put a new implementation into our electronic health record, it has to be implemented across all of the Los Angeles County Department of Health Services hospitals. It can't just be at Harbor UCLA. It has to also be at LA General, at Olive View, and all the other sites. So you have to work with a larger network, which means every one of those other hospitals will say, yeah, we're not exactly sure we want to do it this way. So then you have to get meetings with them and try to figure out what's the best way to serve everyone's needs. You also can learn a lot from what the adults groups have been doing, because they've been at us longer. They've had these challenges and problems much longer than we've had in peds. So they probably already have good solutions that might actually work very well in the pediatric setting. Next. So again, going on staffing and personnel strategies, you should learn how to work with others very well, how to grow your team, I talked about this already, this is worth repeating again, make your project feasible and achievable in a shorter period of time. You also make sure that you have ongoing communication with everybody else, including leadership, and continue to get their buy-in. Listen to their concerns and try to address those, because leadership is not necessarily always opposing you, but they have different problems that they have to deal with and they're responsible for. So it's very good to have mutual understanding of what everybody is dealing with. Leadership needs to show certain outcomes. Leadership needs to show certain progress and needs to show certain financial responsibility and fiscal responsibility. So we can't be asking stuff that costs money and cost hiring and things like that. We've got to be sensitive to all of that. Next. So this is my last slide, I think. So remember that for low-risk patients, having pre-printed discharge instructions, standardized tools like the Stanley Brown adaptation would be extremely helpful. But bottom line is this: what you're trying to do is change, is trying to do something new. You are the first at what's going to be involved here. This is not something that there's a lot of experience with. A lot of your colleagues may not feel that they understand it. It's never been done before. So as I say, here's a not well-traveled road. You may feel a lot of obstruction, a lot of naysayers, but at the end, the goal is for you to sit back and watch how this is ending up changing everything. And the ultimate success is accomplished only by you being extremely persistent, getting everybody's buy-in. Don't take no for an answer. Trust in your abilities, trust your team, and get this done. It is not easy, but it feels great at the end when you accomplish things. And I just wanted to kind of give kudos here to Kate Remick. She's like one of the pioneers in pediatric readiness. The number of times that she's heard no, and finally when things work out, when we show that you got engagement from so many hospitals nationwide that are participating in pediatric readiness assessment. Also, outside of Kate, also Dr. Marion Gasher-Hill and people that came before. This is a product of a lot of effort, a lot of patience, a lot of being able to brush off the nose and keep going. So thank you again for all of your participation in this collaborative and for everything you've already accomplished. And we really are looking forward to the end result at the end when you're successfully established and implemented your strategies. I'm going to pass it on.
Thank you so much, Mo, for that. Thank you for sharing our mid-collaborative check-in survey results, as well as all of your insight on addressing barriers and your motivational words at the end. That was great. Thank you. We can move on to the next slide too. So now we are going to move into our breakout groups. So again, we'll be there for about 50 minutes. And then when we come back, the report out, we'll just be over some summer updates, small wins, if there was any experienced over the summer, or just status updates and just catching up with each other. So we can move on to the next few slides. We're just going to show the breakout groups. We just want to give everyone a quick reminder since we haven't had a collaborative session since June. So this is just a quick reminder for what breakout group your site belongs to. So we can go through those slides, and then there should be something popping up on your Zoom screen that gives you an opportunity to pick which breakout group that you want to join. And if you have any questions at all, feel free to ask in the chat, and we will help you get to where you need to be. Okay, so if you see at the bottom right of your Zoom screen, you can click on join a breakout room, and you can click on what room your site belongs to. Yes, of course, we can roll through the breakout slides again. We can start back at slide 1. And then we will see you all when we get back from the breakout groups.
For those of you who haven't left for your breakout room, if you need help with that, just unmute yourself and I'll help you get to your room.
This is Christina Brent. I'm with the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program. I did not see us on the list.
Hi guys, this is Mo. I'm just showing back up here because I wanted to collect anybody from group 4 that may still be here.
Mo, do you happen to know where the PMHCA groups are going? Are they on the list?
I don't actually. This would be something, I guess, for Eleni.
Okay.
Is everybody here on PMHCA?
This is Christina who was asking that question, I think. And what was the name of that hospital again? It was, I'm sorry, it wasn't a hospital. It was a PMHCA group, but it was in Oklahoma.
Yes.
I'm going to have to message her and see where the PMHCA groups go because they're not going to be on this list.
I don't think that was set up based on that. It might be based on, you know, the region and the hospitals that you're in. And I know PMHCAs don't necessarily work with one hospital, but yeah, that's for Eleni. Sorry, I'm gonna head back now because I just
Okay.
wanted to make sure nobody from group 4 was here.
I will ask her that question right now, everyone.
How do I get to, it looks like I'm team 84. How do I get there?
I'm sorry, which,
Team 84, I'm Rainbow Babies and Children's, UH.
did you notice which group that was
Yeah,
in?
team 84. I just don't know how to get to that room.
So you're in group number 8. So what was your name, sir?
Ron Haydock.
Okay, I'll move you to group 8, Ron.
Sweet, thank you.
Uh-huh. Okay, Laura, are you with the PMHCA group as well? Okay. Christina, she may be in the middle of her group, so I'm happy to put you in any of these groups. I don't recall background on each of them.
I think there was an Oklahoma hospital in group 4.
Group 4.
So yeah, so I'm okay going. Well, I thought it was 4. Wherever
Mhm.
the Claremore Indian Hospital is group 3.
3. Okay. I can move you over there, Christina, or you can select it either way.
Yeah, I can select. Thank you for your help.
Okay, sure, no problem. Carla or Laura, can I help you get to a room?
Sure. I am with Nemaha Valley Community Hospital.
Okay, let's see here. I'm gonna go scroll through these pages and see if you can find your name faster than I
Okay.
can. Oh, here we are, right here in Nemaha Valley in Kansas. So
33.
you're in groups 1, 2. Do you need me to move you over there, or can you select that?
Could you move me over there? Well,
Sure.
let's see here. Break room.
Is
I might be able to find it.
Is this Carla? Nope. Oh, there you are. Okay. Laura, are you still on? Renee Donald. Do you need help finding your room?
Okay, it looks like everyone is coming on back in. So again, welcome back. Thank you so much for your participation in your breakout groups. As stated before, we are going to move into the report out section of this session. So we would love to hear about some small wins or summer QI project updates. And we can go on to the next slide. And I think we are starting out with, yes, group number 8, the suicide squashers. So Jen, we can start with your group.
Sure. So it sounded like overwhelmingly positive feedback from groups. Many are at different stages of their PDSA cycles, but we've heard some positive outcomes, such as like establishing care pathways that have been approved kind of from top down. We've heard, I think, just really some overall successes in trying to get some buy-in with processes. We had some good discussion too around screenings, like how are they being completed, kind of what are, you know, some of the practices that each site is completing. So overall, really positive. I didn't hear overt barriers, or if there were barriers, there were some creative ways to get them overcome.
Great. Thank you, Jen. Let's hear from group number 7, CSIS.
Hi, everybody. Our teams also had some wins to share. We have 2 teams working on Bundle 1. And I think they shared similar wins to mention earlier, having buy-in and getting some good team problem solving going on to overcome some of the barriers that they have been finding around universal screening, how to get the staff buy-in, and how to work through some of those barriers. Other teams also, most of our other teams are doing Bundle 4. And on those teams too, there's lots of wins shared over resources being created, thinking through ways to get those resources into discharge paperwork, into the hands of whoever needs them. Big initiative on firearm safety education, and providing again, written information to families for discharge around all of these topics. So I think lots of progress being made. I think the barrier that most people shared was around EMR and how to make all of this work in the records for the providers to be able to have this work be done feasibly.
Thank you for sharing that, Vera. Okay, we can move on to group number 6, Sunshine Mood Movers.
Alani?
Yes.
One more thing.
Oh, of course. Yeah. Sorry about that.
I just wanted to mention that one other small win that I thought of was that one of the hospitals started out with 0 in terms of giving certain kids handouts and discharge instructions. And then they moved forward to 3 out of 15 kids. So small win, but 3 children and their lives were impacted. And that's really important. That was it.
Thanks.
Thank you, Laura. Thank you, Vera.
And for group 6, I had a lot of work being done over the last couple of months. They've seen anywhere from implementation into their EMR to drafts being ready to go to advisory committees, and really tools or resources that are drafted and in the process of approval and editing. A lot of work being done.
Awesome. Thank you, Casey. We can move on to group number 5, the Fabulous Fivers.
Amazing successes shared today. About half the teams are focused on screening, half on assessment. All of them have obtained significant cultural buy-in, which is a huge win. One, so much so that they're able to expand this work across their entire hospital network or hospital system, which is really, really cool. Some points that have been leveraged are looking at accreditation standards to try to, incentivize this work and get that buy-in, bringing in leadership, ED charge nurses and other leadership teams, ED medical directors. All of the teams have gone so far as to rewrite policies, protocols, start putting together or have already launched education for staff, have been working with IT to build out these protocols within Epic. Some have already gone live and are beginning chart audits, and it's just amazing to see this work. So kudos to all these teams.
Thank you so much for sharing, Kate. We can move on to the Fantastic Four.
Anna, were you going to cover or you want me to?
I can cover
Go for it.
if I can find my notes. Why don't you start? Well, no, I'll add.
Yeah, I know since Anna has the notes, she's going to give you more of the details, but we also had a really good engaged group, and it seems like there was a mix and match of bundle 3 and bundle 4 ED-based interventions and safe discharge planning. One of the groups specifically looked at the patient's Bill of Rights and specifically trying to make sure the activities of daily living are met, including the meal service. And there were some challenges there with whether or not the hospital is going to charge for those or not. So that was kind of interesting how detailed they got into trying to solve their problem. There is also one group that has a mental health packet to be delivered that also includes a small kind of session with the patient upon discharge to go over how to use the packet. And a challenge there was who is going to do this, because the ED is busy. So they actually have a process where a social worker will do that work while they're available, and during the off hours, it would be the supervising nurse that actually takes the lead on that. Potentially there'll be nurses and physicians that are going to also participate, but it's going to be interesting to see that. A lot of the work is already done in developing those packets. And yeah, so overall, I think that every team is working really well. Some of the integration into EHR obviously is a challenge. So people are working on basically paper-based forms and activities that can be scanned into the EHR. And one suggestion that I made is if they can have a simplified version of the form that actually lives in the EHR, they can keep track of it for the purpose of billing and things like that. And I don't have a lot more details, but if you have anything else, you jot it down quickly if you want to add.
Oh, yes, thank you. Just a few things to touch on. The largest barriers, I think, are going through the approval process of different departments, and so the teams are in different stages of that. Just to add to your overall notes. Other than that, that's it. Thank you.
Thank you so much, Mo and Anna. I can speak for group number 3. So some wins that our group had over the summer is we had a group focusing on the suicide screening bundle. They are moving forward on lowering their screening age down from 13 to 10. They're waiting on the policy approval, but there has been progression on moving forward on lowering that age. There's also a new parent intake form being created. They have met with different outpatient units to ask different questions to help create their draft. They're going to be presenting it to their ED nurse staff in a meeting soon, and they are going to be testing that out and working on creating a Spanish version as well. Another win that we had was a telemed psychiatry system being created, which has video chat features with the patients and families being created for assessments for discharge, with an education portion too, which was very cool. And they are shooting for an end of the year launch. So those were some wins to note, but also a win for the collaborative was something we were talking about at the end, was how our participants really want to stay connected post collaborative, exchanging resources, emails, things like that. So I thought that was a nice win for the collaborative as a whole, and that is something that we are working on too. So that is for our group for allies, and then we can have our last group. I think Lisa or Julie can take it away for Saturday Night Fever and Rural Rules.
Hi everyone. So our group, Saturday Night Fever, Rural Rules, unfortunately we only had one team able to be present today, but it was actually a fabulous opportunity to have some one-on-one time to talk through a couple things with her, a specific case, and maybe some debriefing opportunities to work with some of their outsourcing or telehealth resources for screening. But we talked a lot about where that team is in their process. They are doing bundle number 4, the discharge instructions and resources. Made progress there and feel pretty good about where it sits. So really, we actually spent most of our time talking about that case and maybe some opportunities for improvement from that particular event. So that's all I have.
Great. Thank you, Lisa, for sharing that. Okay, so we can move on to our next slide. Thank you, everyone, so much for sharing. So I would like to highlight 2 newly released documents published in the American Academy of Pediatrics. I'm going to hand it over to Mo very quickly, and let him talk about this.
Yeah, this is just really brief. This is a joint policy statement between AAP, ACIP, and ENA. It's really a product of 3 years worth of a lot of people's efforts trying to align the recommendations and the thoughts about managing pediatric mental health, especially in light of all of the severe escalation in the numbers and the acuity of behavioral mental health patients that come to the ED. Some of the features of this is essentially that we are looking at the entire continuum of care. There is things for pre-hospital, there's things for the ED, there's things about discharge planning, and there's things with the community as well as research. So all of those elements are included. There's a technical report that goes with the policy statement. The policy statement is more of a shorter version and actually can give you recommendations. We talk in there a lot about things like telehealth, regionalization of care, recognizing that we don't have a lot of pediatric psychiatrists available and that we should make sure that we make efficient use of that. Also being able to provide accurate screening so you can identify those with higher risk among the many, many, many who show up. So prioritizing your resources for those who have the higher risk. Also looking at disparities. There's a big section on disparities. Pediatric mental health does not affect everybody equally. There's some groups that are disproportionately affected. We specifically talk about those. A majority of this is going to be basically ED-based interventions and what you do as a emergency physician who really doesn't have enough psychiatry training, and how do you manage those patients during their stays and things like that. So it should be pretty good read. The QR code in there is for the technical report, but when you go to technical report, you'll see that next to it, there's some a link that you can go to the policy statement. So I just wanted to bring attention to that. And I think this is a great resource. Like I said, a lot of people worked really hard for 3 years to make this happen. Thanks.
Thank you so much, Mo. Yes, we're very excited about the release of those documents because serving as lead authors as part of an extensive writing team were 2 of our own experts, Mo, and also Dr. Susan Duffy, who was not able to be here today, but we are very excited about those documents being released. So thank you, Mo, and to everyone else. We had some fireside chat experts who were part of that writing team too. So very excited about that. Okay, we can move on to the next slide. Thank you. And then I will go quickly on this because we are at the top of the hour, but next steps, just keep improving or keep continuing on with your improvement journey. A good way to do that is to compare your current progress to your SMART aim, seeing what you have done, what needs to be done, where you want to be going forward. And then another step for moving forward is to consider how to sustain these results and implementation strategies. Our October session is going to be all about sustainability planning. So we are going to dive into that in the October session. So we only have 2 ED Stop Suicide QI collaborative sessions left, and the dates to note for those are October 5th and November 2nd. And we can move on to the next slide. I think at this point, we are going to have our session evaluation poll launch. So please stay to complete this. We really value your feedback. And after this, we will get the nursing link out to you in the chat. But thank you so much for filling out this poll for us. And then we can also move on to the next slide. So we are able to show the QR code for nursing credits as well. Thank you. We'll put the direct link in the chat as well in 1 second. There is the link too. If you want to use the link instead of the QR code, go ahead and use that. And then as we are at the top of the hour, that's all we have for everyone today. So thank you so much, all of you, for joining, your participation in the breakout groups, and all of the amazing work that you do to make this collaborative possible and to care for kids. We really appreciate all of your hard work.